I'd like to begin first with Dr. Chang.
Chairman Smith and esteemed commissioners, thank you so much. Thank you so much for holding this hearing and inviting me to speak about the importance of the healthcare system and its professionals in rescuing victims from human trafficking. I'm going to start off with a story as well. One night in 2008, Christina, a patient of mine, came to the clinic very sick. She was young. She was about 15 years old and had been seeing us at the clinic for 3 years. Although she never disclosed any sexual exploitation, we suspected that she was being sex trafficked. That night, she had a high fever, rashes all over her body, swollen joints everywhere, painful. She couldn't walk. She had a racing heartbeat and weighed less than 90 pounds. She was anxious and depressed. She had delayed seeking care despite feeling ill for 3 months. She needed to go to the hospital. When I told her this, she absolutely refused, saying to me, "I'd rather die than go back to jail." I didn't quite understand the connection between her going to the hospital and her being sent to jail. Later, I learned that on a previous hospitalization, Christina was discharged to jail because a bench warrant for her arrest was issued when she failed to appear in court on solicitation charges. Christina did not go to the hospital that night. I feared she was going to die that night, and we had failed our patient. Or had we? Later that night, our care did not end when Christina left our clinic walls. Our health center's youth program outreach workers and the case manager of Bante Sre, our program working with sex-trafficked minors, worked their community connections all night, eventually locating her the next morning. The Bante Sre case manager went to Christina, convinced her to go to the hospital, and personally drove her there. She was hospitalized for almost 2 months, treated, and she survived. For Christina, our team-based approach, our assistance enabling her to access care, our public health perspective, extending outside of the clinic walls, and our community health center model was a success. This model can be a success for many more victims across the country. My work with human trafficking victims as a frontline physician has focused mostly on the role of the community health centers, and so my comments will carry that perspective today. I hope to answer the questions: what is the responsibility of the healthcare system in addressing human trafficking? What are the unique opportunities and advantages of community health centers in preventing, intervening in, and ending human trafficking? And third, what can government and Congress do to interrupt and intervene in and to enable community health centers to effectively care for trafficked patients? Christina's story highlights the healthcare system as a critical access point for reaching victims. Because of the very nature of human trafficking, you've heard from Selena and Roxana, victims experience severe physical, mental health, and social harms in the short and long term. So Christina suffered from all 3 types of harms that night: a possible sexually transmitted infection, depression, anxiety, and criminalization. So physical harms, mental health harms, and social harms. And here she was in my health center, severely ill, a trafficked patient, refusing to go to the hospital. Her fear of being jailed for the very victimization causing her illness placed her at risk of dying. Overall, our response as a society to victims is simply inadequate and flawed. When I think about those trafficked, I think about how underground and hidden victims engage with systems of care and protection in an above-ground functioning society. The focus of the criminal justice strategies to reach victims and to end labor and sex trafficking is limited, reaching only a select few. In 2006, Asian Health Services conducted an internal survey of the Bante Sre Youth Development Program for the sex-trafficked minors. And we learned that out of the 40 girls participating in the program that year, only 3 of them had a law enforcement interaction. This means that 93%, almost 93% of the patients who are being sex trafficked participating in our program were not being reached within the criminal justice sector. Yet they were engaged with the healthcare system. So relying on a justice framework to identify and reach victims means that we miss many others who don't receive, don't qualify for, don't want to use, or are excluded from criminal justice services. And like Christina, many of the victims are treated like criminals. So this call for a robust public health and healthcare system response to human trafficking it has been echoed by justice and law enforcement leadership. The foremost priority of the criminal justice system is to uphold the laws of the state. In best cases, the state interests overlap with victims' needs, but sometimes those interests are at odds. When victims feel too scared or hopeless to participate in the prosecution of their traffickers, or when they don't have a strong case for prosecution, does that mean they won't get the services and the healing care that they need? Separating the priorities of the state in prosecution of traffickers from the priorities of the victims in healing may yield better results in ending trafficking by allowing victims the time to heal and regain agency over their lives. With one possible outcome being that eventually they'll be strong enough to participate in that prosecution. Compared to other sectors in a functional society, the healthcare system provides opportunities for interaction and engagement throughout the entire lifespan, from pregnancy to childhood to adulthood, from acute emergency care to long-term chronic care, from public health outreach to hospitalizations. So all points of care are opportunities to prevent and start the process to end human trafficking. It's like a long-term process of rescue. So when I think about the healthcare system, I think about the whole team of professionals who provide care. Christina's engagement began outside of the clinic walls when the youth program told her about our services and educated her about the harms of commercial sexual exploitation and sex trafficking. That outreach enabled her to access the clinic. And the Bante Sure case manager enabled her to go to the hospital. She actually went and provided that transportation, enabling her to access care, to get the life-saving treatment that she needed. So Christina's not alone. Studies showed, and one of them was Dr. Lederer's, that between 28 to 87% of trafficking victims had seen a health provider or clinic. I think that community health centers are the best healthcare response to human trafficking. Like Christina, untold numbers of trafficked people are accessing care at health centers, and there are many community programs. A study I published this year shows that trafficked minors can be identified in the community health center setting when they're asked those questions. Although there's no single profile of a human trafficking victim, people vulnerable to trafficking include runaway youth, foreign nationals with a different language or culture, poverty, and those with a history of trauma or violence. There's significant overlap between the trafficked and at-risk trafficking victims with patients who are seen at community health centers. So at the community health centers, we see a disproportionate share of the nation's poor and uninsured. Most are members of racial and ethnic minorities, and millions of health center patients are served in a language other than English. Asian Health Services is not the only clinic doing this work. There's other models that are developing to provide integrative care for trafficking victims. There's a partnership in Honolulu between Kokua Kalihi Valley Community Health Center and the Pacific Survivor Center. We provide this care despite scarce resources. So health centers are also unique because they provide these enabling services. You heard Roxanne and Selena talking about how their handlers were answering all of their questions, and they were providing the interpretation for them. So in community health centers, we provide special non-clinical help, enabling vulnerable patients access to care, including things like interpretation. At Asian Health Services, we have interpreters in 12 different Asian languages. So finally, community health centers serve more than 24 million patients in over 9,000 sites across the United States. This equals millions of clinical and non-clinical opportunities in that system to reach out to, identify, and help traffic patients. So with all this in mind, I have some recommendations to help shift the care for victims from the criminal justice sector to the healthcare and public health system. 1, create wraparound care teams in community health centers across the nation, focus on reaching out to and providing care to victims of human trafficking. 2, create human trafficking specific programs like Bantesre within health centers to address the physical, mental health, and social harms that result from being trafficked through all the stages of trafficking, from prevention to long-term care. 3, ensure language accessibility for victims and cultural competence by professionals throughout all systems that engage with human trafficking victims. 4, ensure that non-clinical assistance enabling victims to access care is provided throughout the healthcare system. 5, incorporate trauma-informed care training throughout all systems that engage with human trafficking victims. And finally, please direct the federal agencies to consider health impacts, physical, mental, and social, of anti-trafficking policies on victims and survivors. So in conclusion, let's get back to Christina. So our team that night was successful in getting her treated at the hospital. After 2 months, her physical health improved. She was ready to be discharged. But guess where she was discharged to? She was discharged directly to the county jail. So we can and we must do better. Thank you.
Thank you so very much for those, not only the insights, but the recommendations, which I think will help all of us come up with a better plan. Thank you, Dr. Chang. Ms. Garcia.
Thank you. First, thank you so much for the opportunity to speak in front of everyone here. I really appreciate the opportunity to do this. Thank you. I work with survivor victims of sex trafficking and labor trafficking every single day. I'm here to tell you some of the recommendations that I would like to see, but also to tell you about some of the issues that we're still experiencing. The average sex trafficking victim, as you heard from Selena and from Roxanne, could be serving 30, 40, 50 johns a day. Take, for example, the story of who I will call Adele, who was found on a Sunday, and on Saturday, the day before, she reported serving 70 johns in one day. As you can imagine, the repeated exploitation that happens to these victims creates many, many health issues that, of course, also end up being chronic. I would like to explain some of the physical abuse that these victims sustained over time while being handled. These include punching, slapping, hair pulling, ear pulling, being beaten up with sticks and belts and shoes, choking, smothering, and of course also being repeatedly sexually assaulted by the handler as well. I'll give you another example. This person I will call AT. She was recruited at age 17, and whenever she complained or whined or made remarks about stopping, she was locked in a room with no food while the trafficker continued to sexually assault her. In her case, she was trafficked for 5 years, also had contact with the healthcare industry. No one asked a single question. Every single time she was discharged back to the trafficker. Here's my second point. Minor and adult victims of sex trafficking may appear to be junkies or addicted to illegal or prescription drugs when they show up in the healthcare industry. It is part of the trafficker's control method to create even more vulnerability for the victim by keeping them addicted to drugs. Because they have been forced to use drugs from the time of recruitment, by the time that they show up in a healthcare facility, they're drug users and addicted to something. For example, in the case of who I will call BT, she was 14 when she was recruited and forced to use drugs on the second day with the trafficker, and every day after that. In her particular case, the trafficker would decide what drug he would force her to use, whether it was injected or by mouth. Sometimes she was given drugs that would make her hyper and active because she was expected to serve dozens of buyers, sometimes in parking lots. Other times, she was given drugs that would create unconsciousness because she had a certain buyer who wanted to perform certain paraphilic behaviors that she was not okay with performing. So while she was unconscious, these things were done to her. She was recruited at age 14, trafficked for 5 years. Because of the repeated sexual exploitation, physical abuse, the drug use, the victims end up having at least one or repeated encounters with the healthcare providers in our system. Here are my points for the healthcare providers. First off, we need to understand that more time needs to be spent assessing the difference between perceived prostitution and self-voluntary prostitution. Victims are still being treated with confusion regarding the symptoms they present and the stories that they tell as to whether or not it may be prostitution, even when they're minors. We are not asking intake staff, nurses, doctors, and health social workers to become investigators or experts. We need them to understand the unique aspects of complex trauma, the bonding that happens between the victim and the perpetrator as it happens in human trafficking, and that there is a process of incremental disclosure where unless you spend time talking to this person, they are not going to disclose what's happening to them. Second, healthcare departments of everywhere in the United States, in every state, needs to have appropriate protocols in place that must be strictly followed. Even when a patient is denying being forced or coerced, but the medical personnel is suspicious that something is going on. Assuming that it's just prostitution increases the risk of a victim not being helped and being discharged back to the perpetrator, as we saw in the case of Roxanne and Selena. Signs, symptoms, and self-disclosures of prostitution-related activity should be treated all the same by medical professionals. Even when someone is saying, I'm prostituting and I'm doing it on my own, the protocols still need to be followed. Any of the previously mentioned signs, physical, psychological, the signs that Roxanne and Selena talked about, all of these need to be considered by medical personnel as enough to make an additional phone call to the appropriate state, local, or federal law enforcement or non-governmental organization in the area the facility is located in. In most cases, especially in the case of adults, likely the first person that should be called is an NGO rather than law enforcement. That NGO could lead to law enforcement. That NGO could be the person that they trust first. Third point. All hospital personnel that comes in contact with patients have to understand human trafficking. There should be at least one individual in each department that has been uniquely trained to be able to interview and talk to a potential victim. Specific ways of interviewing have been found to be more successful than others. For example, we have found that utilizing the word help is a trigger to the victims because they have already been forewarned by traffickers that they are not to accept any help, that they are not to act in any way that's going to cause someone to think that they need help. So utilizing the word help by medical personnel is going to automatically trigger them to say, no, I'm fine. What needs to be said is something like, there is this person that's going to come and talk to you. This is part of our protocol. And that person needs to be uniquely trained to learn how to gain their trust and to be able to maintain that trust with that victim. Next point. All personnel must have appropriate access to numbers and know who to call whether it's services for minor or adult victims, which many times are different from state to state. The services that are provided to minors and the ones that are provided to adult victims are different in many states, and the medical personnel should know the differences on who to call. It is no longer okay for medical personnel not to respond correctly due to lack of knowledge or not being able to understand what's going on. They must know who to call and how to respond so that the process of helping the victim goes through. It's no longer okay for medical personnel to discharge patients without creating some type of connection or providing additional assistance outside of the medical facility for the victim. The victim should at least leave with some form of information on how they can get help if they decide to do so eventually. Many times we have seen cases where when they make contact initially with a healthcare provider, they may not be ready to talk, but 2-3 days later, because they're upset or they got a beating, or they had an opportunity to make a call, they will call. But what happens when they're discharged and they have no one to call, no information, no number? Now we have nothing. Interagency, and by this I mean law enforcement cooperation and NGOs, is critical. There has to be a relationship. Because of this process of incremental disclosure, which may take a long period of time, it is essential that healthcare facilities develop relationships with all of the agencies that are going to be involved. Last, I'm going to leave you with this. I have personally seen this. When protection procedures for these victims in the healthcare facilities are consistent, honest, and reliable, the victim can feel supported and encouraged throughout the internal disclosure process and maybe will agree to receive help at the moment or later on. This can surmount current difficulties in supporting survivors over time and through the physical and psychological difficulties of stepping out of the trafficking environment and the post-trafficking process of restoration and rehabilitation. Thank you.
Garcia, thank you as well for, again, your very specific recommendations and the insights that you have provided. They will all be used, I can assure you, very effectively by this commission and by other members of Congress. So thank you. I'd like to now, Dr. Greenbaum.
Thank you.
Yield.
Good afternoon, Chairman. Sorry. Good afternoon, Chairman Smith, distinguished commission members, and members of the audience. I'm grateful for the opportunity to testify before you today. In addition to my oral testimony, I would like to submit written testimony into the record. My name is Jordan Greenbaum. I'm a child abuse physician at the Children's Healthcare of Atlanta Stephanie Blank Center for Safe and Healthy Children. I'm also a consultant for the International Center for Missing and Exploited Children. The Blank Center provides medical and behavioral health services to suspected victims of abuse and their families. The International Center for Missing and Exploited Children is a non-governmental organization that combats child trafficking and child exploitation globally. I'd like to provide testimony today on sex and labor trafficking, especially involving minors. As you know, and has been said a few times, reliable estimates of the incidence and prevalence of human trafficking throughout the world are not available. But the best estimates indicate that millions of adults and children worldwide are involved in trafficking. Victims of human trafficking may experience a plethora of physical and emotional adverse consequences, including traumatic injury from physical assault and sexual assault, work-related injury, sexually transmitted infections, post-traumatic stress disorder, major depression with suicidality, and anxiety disorder. Despite the criminal nature of human trafficking and the desire of traffickers to elude detection, we do know that victims come into contact with healthcare providers. We also know that victims rarely self-identify and may even deny victimization, as we've seen very eloquently. Therefore, it is incumbent on the healthcare provider to recognize signs of at-risk youth and adults, to ask questions appropriately, and to provide trauma-informed care to identified victims. The problem is, how does a healthcare provider recognize a potential victim if they don't identify themselves as such? This is a real quandary. At Children's Healthcare of Atlanta, we recently conducted a pilot study to describe characteristics of sex trafficking victims. Based on that data, we designed a 6-item screening tool, and a cutoff score of 2 positive answers was determined to have a 92% sensitivity for identifying child trafficking victims. A child with a negative screen had a 97% likelihood of not being a victim. Now, our study results need to be validated with other adolescent populations outside Atlanta, and currently we're conducting a multi-site study. Beyond knowing what questions to ask and when to worry, healthcare providers need to know how to interact with potential victims in a way that does not re-traumatize them, that encourages trust and honesty. A trauma-informed approach is absolutely essential. This approach to patient care involves the medical provider recognizing the real possibility that patients they're interacting with have experienced some sort of trauma, and that this trauma may influence how the patient responds to questions, how they respond to interactions, their behavior with healthcare providers and others. Victims of human trafficking have almost certainly experienced complex, repeated, severe trauma. And this combined with their additional distrust of authorities, their fear, their shame, their humiliation, makes it very difficult for healthcare providers to interact with them in a way that's appropriate. It's quite a challenge. It's not easy for a healthcare provider to consistently respond with support and understanding if a patient appears hostile, disinterested in receiving help, or protective of the trafficker. But these reactions may be all related to trauma. The victim is responding to their trauma, and it's imperative that healthcare providers understand that and not respond inappropriately. But again, a calm, non-judgmental, supportive approach may be the only way to convince a victim to disclose their victimization. But that's not an easy thing, and healthcare providers are not necessarily trained to do that. In medical school, we are not trained to do that. In nursing school, they are not either. So this is something that has to be learned, and we have to set about training professionals on doing that. The problem is that many curricula have been designed and implemented throughout the United States, training healthcare providers. Lots of webinars, lots of training scenarios, but almost none of these have been formally evaluated to see if they're really effective. And this is extremely important. Before we invest thousands, hundreds of thousands of dollars trying to teach hundreds of thousands of healthcare providers how to respond, we need to know whether these curricula are effective. There are some exceptions to this. At Children's Healthcare of Atlanta, we developed a 6-part webinar series on child sex trafficking designed for healthcare professionals. Results from the post-webinar survey documented significant changes in beliefs about trafficking. And in a 6-month follow-up survey, we found a significant increase in the percentage of webinar participants who are now asking adolescents questions about risk factors related to sex trafficking. And that represents an important and persistent behavior change. In general, healthcare providers are not trained to actively seek relationships with non-medical outside organizations. We're just not good at that. We don't feel comfortable doing that. And so that's another thing that has to be learned. We have to have a paradigm shift. Healthcare providers tend to work within the healthcare system. We're very good at interacting with each other, but not so good with interacting with other people and other agencies, and that has to change. It's a critical step in the process of caring for patients who are trafficked victims, because we need to be able to bridge the gap between the medical world and the community agencies that can provide the services to victims. The HEAL Trafficking Organization is developing a protocol that will provide step-by-step assistance to healthcare providers who want to work with their community to develop an anti-trafficking multidisciplinary team. Such a tool will help providers bridge that gap between the medical clinic and the community services that are so important for survivors. And finally, I want to discuss the World Health Organization's International Classification of Diseases. This is a system used by healthcare providers worldwide to code all symptoms, diagnoses, and procedures related to healthcare. The ICD codes are very important because they're used to monitor incidence and prevalence of health problems. and provide critical data for monitoring world health. Currently, there are no specific codes for human trafficking. And this makes it extremely difficult to obtain epidemiologic data about human trafficking and to study health complications related to human trafficking. In December 2014, the International Center for Missing and Exploited Children initiated a proposal to the World Health Organization to adopt specific ICD codes for child sexual exploitation and adult sexual exploitation. In early 2015, the HEAL Trafficking Organization initiated a similar proposal to the World Health Organization, asking for codes for labor trafficking. These codes will support the initiative of the SOAR to Health and Wellness Act by providing, quote, a reliable methodology for collecting and reporting data on the number of human trafficking victims identified and served in healthcare settings, end quote. The International Center and HEAL Trafficking are eager to see the proposals accepted and are seeking support from other stakeholders. In conclusion, human trafficking is a public and private health issue, and healthcare providers play a critical role in identifying victims. They need training to know how to recognize victims and how to respond appropriately, and specifically, this includes trauma-informed care, how to respond, how to ask questions, how to do that in an empathic way that doesn't discourage victims from coming forth. They need to be able to work with community providers, to reach outside the medical system, to help bridge that gap so that survivors have somewhere to go. So we need to train them on how to do that. This training needs to occur in the United States, but also overseas, because trafficking is a transnational problem and requires a transnational solution. Thank you for the opportunity to speak to you today.
Thank you so very much, Dr. Greenbaum. I'll begin with a few questions and then ask our two ladies if they would want to come back up to answer any questions from either myself or anybody in the audience. First, Dr. Chang, you mentioned 93% of the victims didn't have any contact with law enforcement. Did any percentage of those victims, as they went through your program, decide at some point, and how long was that lag between when they had enough confidence to bring a case or to identify the perpetrator of the crime, and what was the outcomes? Did that give them any sense of empowerment that the person that had done such horrific things to them has now been held accountable and at least not do it to others?
Well, actually, you bring up a very good point, Chairman. We actually have a protocol in place now where we will, as a healthcare provider, we suspect any sex trafficking of minors, we will make the report to the child abuse professionals. We also make a same-time report to the police department. However, what happens is these two systems were not built necessarily to address this problem. So the child welfare department says that it's not abuse committed by a caregiver, so refer to the police. The police say, is your victim willing to make a report? And no, they're not. So we do make these reports in the hopes that the data is being collected so that it can show down the line that this is a very big issue in our community. But as of yet, there are no systems responses that are coming in to intervene within our clinical setting.
Does it at least add to the surveillance of a potential trafficking area? We just had a case in my own district where we got some, what I think was actionable information. We got it right to the FBI and to local law enforcement in that order, and they are now looking into that matter very aggressively. Do they at least follow it up in that way?
I think they do follow it up that way. And in fact, in California, they did just a couple of years ago change the reporting requirements for child abuse to include suspected sex trafficking.
And in terms of the community health centers,
yes,
has the National Association at all looked into this as a protocol?
That's
want to follow?
I hope they are, and in fact, they did invite me to speak on a human trafficking panel last year. So we're getting on that with the Association of Asian Pacific Community Health Organizations, which is a member of NAC as well.
We recently had a huge bust in Lakewood, New Jersey, which is in my district, of a number of Mexican traffickers and women who were liberated who lived in Lakewood. We do have a community health center, and frankly, I've been working on this since 1980, 95, not 85. And while I've been to the community health center, we are checking now to see what it is that they do. I think you inspire all of us to look into our own. I have 3 in my district, and they serve a very, very compelling need for health care. And they do have trauma, because that is, as you've all said, a very important component of all of this. So thank you for that insight as to part of the remedy to helping. In terms of faith-based, do you find, all of you, that you seek to integrate the faith-based community? I've been in shelters all over the world, both as well as in the United States. I can tell you that, at least in my view, where there's been some connection to faith, the healing process, mental health, opens up doors, helps diagnose the problem. Psychologists, psychiatrists do wonderful work, but when it's done in companion with a faith-based approach, the deeper healing often can occur. I was in recently 2 shelters, one in Lima, Peru, the other one in La Paz, Bolivia, and both were supported by the governments. And to have the Bolivian government support something, given Evo Morales' viewpoint towards the church, which is not a good one, and yet that government does support this faith-based initiative in La Paz. But I met many women, young women especially, who were there, and the key was longevity, or a key. They weren't there for 2 weeks. It wasn't a shelter just to get out of they were there in some cases for 2 years or longer. But they learned life skills. They were learning computer skills as well. But they had a joy that was just remarkable. In like manner, I was in Goma, in the Democratic Republic of Congo, where many women had been subjected to sexual abuse and rape based on war. And again, in Heal Africa, another faith-based group, they were having incredible results, not only treating the physical side as best they can, but also the mental health side, but the spiritual side as well. And I'm just wondering if you find in your walk that's a component that you embrace and feel should be a part of this.
We certainly see a strong faith-based interest and I'm from Georgia, and a lot of faith-based organizations are very interested in the anti-human trafficking effort. So they put a major effort into creating homes and safe houses and putting forth a lot of volunteers. So it's extremely helpful.
As well here, in the same format as well, providing places that are safe. One of the things that I have noticed with the point of contact, point of rescue program that is mentioned there, with this program, it's like a triangle effect where we teach the healthcare personnel, law enforcement, and the hotline all to respond to calls. And work together in this way. Where the faith-based, I find, has helped is through the process once they have established some type of connection or relationship with the healthcare provider, whether it's the psychologist or a counselor, whoever it may be. I find that having a neutral person that they maintain contact with really helps through the process of that incremental disclosure that eventually may lead to prosecution, or successful prosecution, I should say. So having that neutral contact that's consistent is essential. And in my case, in most successful cases, it has been a neutral party. So it's not a law enforcement person, it's not the pastor of the church, and it's not the doctor. Is someone else who the child or the adult is seeing outside of the system.
You did say call the NGO rather than law enforcement, or at least first.
Especially for
Are there
adults.
enough NGOs, in your opinion?
No, and this is one of the suggestions. They're probably both shaking their heads no. This is one of the suggestions that needs to be made, that in every county, in every state, there has to be an identified NGO that can respond to these calls outside of the Department of Children and Families.
Yes, please.
Thanks. I wanted to address the spiritual, the faith-based response. I think it is essential, and in fact, sometimes traffickers use a deeply held faith by a victim as a form of abuse, For example, I did some work in the Western Pacific and in the Pacific jurisdictions, and there was a young girl who had been sex trafficked and raped and kidnapped forcibly, and the trafficker repeatedly told her that her God no longer loved her because she had been defiled. And so I think the healing component is for spiritual aspects is very important.
Ms. Garcia, you mentioned upon leaving an emergency room or health venue, they need to know who to call. Now, how do you convey that if the handler is as was said earlier, even to the point of being with her during the birth of her child? How do you get that information? I mean, do you look for, does a specially trained person look for, some place where they close the curtain, say everybody out, and then they just do it like you're doing in a
Correct. That's exactly what we are training the hospital personnel to do through point of contact, point of rescue is first off, you must get everyone to leave the room. And medical personnel, by the way, has that authority in every state. They can ask everyone to leave the room and then conversate with the potential victim about, I'm going to give you this information. Where could you put it? How could I help you memorize it? Take it with you. I know you don't want it right now, but if you do later, I want you to have it.
Have there been any instances where the trafficker or the pimp found a card, business card, something with a phone number on, and then?
Yes, I have had those cases, especially with minor victims. However, is few compared to the cases where it hasn't happened.
Right.
Can I just add something to that? I think I do a lot of training of healthcare providers, and two of the questions they almost inevitably have are, how do we get the person out of the room so we can talk to the child alone? And what do I do if the child refuses to stay and I need to make a report and they want to leave? And the answer to the first one is that we usually say, it's our policy here at Children's or the clinic or wherever you are, it's our policy here to interview all adolescents alone, so I'm going to need to have to ask you to step out, and there's a waiting room down the hall. Can you just step this way? You're not really asking them, you're sort of telling them, but you're saying this is a policy. We do it for all parents. And so the person usually goes. If they don't, if they refuse to leave the side of the victim, like in your case, what I would suggest is that the healthcare provider come up with a different scenario, saying, we need to get this child a chest x-ray and we're going to need to take her to radiology. Or we need to draw some labs. We're going to have to take her to the laboratory. And so you escort the child or whoever the patient is, you escort them out and leave the trafficker in the room. The other thing that I think refers to what you are getting at as to how do you give information to a patient in a safe way, and that is, I think, very difficult, and we have to be very careful because no one knows more than the patient how safe they are and what will put them into danger. And so I agree, we have to be very, very discreet about that and say, can I give you these resources? And if not, if they say absolutely not, then we don't. But we can leave the door open and say, this is a safe place to come. If you decide to come back, come here. We can offer you services. That's all we can do. But
Sure. Dr. Chang, you talked about the fear of jail. And I'm just wondering, when and I was the prime author of the Trafficking Victims Protection Act, one of the areas that we had a great deal of headwind to overcome was the T visa and providing safe haven and really doing a sea change in terms of saying these are not perpetrators of crimes, these women are victims, or men, but most obviously in sex trafficking are women. And that is the law. Matter of fact, the definition, anyone who's not attained the age of 18, by definition is a trafficking victim if just one commercial sex act is committed. And then force, fraud, or coercion for anybody after they have attained the age of 18. So the fear of jail is that law enforcement is not sufficiently aware. Is it the local or state laws that are the problem? I mean, federal law, I think, is clear, but what's your thoughts on that, Dr. Chang?
Thank you for asking. That's a wonderful question, and you're right. It's federal law clearly defines my patients as victims. I think it's taking time for the state laws to catch up, and also the application of state laws by the different counties and the different prosecuting attorneys, depending on the states and how they divide out their law enforcement and criminal justice system. So in California, there are still counties that are able to arrest minors for solicitation.
I think it's also that the traffickers will threaten the child, or the patient was saying, you'll get arrested and I won't. If you go to law enforcement, they'll arrest you and throw you in jail or deport you.
In the case of Selena, she was held in state federal prison for 3 months when she was found, for 3 months. And again, this goes back to not utilizing the appropriate services that are available, and law enforcement not understanding that other services also have to be provided. That it's not just you interviewing and prosecuting a case. This individual has to be allowed to have a process where they go through that process of incrementally disclosing what they want to disclose. Sometimes law enforcement has an idea that because they're victims, they should be ready to talk. Because they're victims, they should be ready to be rescued or be helped. This is not what we see with human trafficking. We're talking about very, very complex trauma bonding that happens between the victim and the perpetrator.
Roxana earlier had spoken about the handler staying with her even as the baby was being born. And my question is, are these handlers, these pimps, that good of actors that they can deceive a group of very highly competent, medically speaking, certainly, people? Emergency rooms are tough places to work. Are they that pressed for time, or is it the sense of, don't ask questions, just be indifferent, just handle the patient, and don't judge or some nonsense like that, where you're not judging, you're ascertaining the nature of the situation. But it seems to me that there would have to be giveaways at all times.
Okay.
Go ahead.
I think there are a number of factors, and it probably differs with different physicians. I think certainly time and requirements for productivity drive a lot of behavior for medical care. They have to see a number of patients, and they have to keep going. There are 16 patients waiting to be seen. I think there's also discomfort. I'm not sure how to ask these questions. I don't know what to do. I don't know. What if they say, yes, they are a victim? I don't know who to call. So if I don't ask, I won't have to respond.
Let me ask you on that. Is the American Hospital Association, are they promulgating recommendations for their own hospitals? Because they are a huge network.
I think that's a very good point. I don't know that they are. We are working very hard with individual medical organizations to try to get policy statements. For example, the AMA has issued a policy statement saying physicians need to be trained on how to recognize and identify victims. And so a number of these medical organizations are working. But I think your suggestion of the American Hospital Association is a very good one.
I will offer, if you want to work with us, we'll write a letter to the AMA.
Yes.
AMA is already doing it, American Hospital Association.
Yep.
And others, asking them specifically as a Helsinki Commission, what are they doing? Will they do it? And help us tell them or convey to them, what a best practice would be for the hospitals, what you're doing. But I mean, we'll work on that immediately.
I think the whole thing having to do with trauma.
And we'll invite them to a hearing.
The whole idea of trauma-informed care is such a sea change for the medical world, for people to really take the time to ask people about possible trauma and to interpret their behaviors as possibly reflecting their traumatic experiences. And to take that into account is so different than what we've been told and taught in medical school and nursing school. It's a hard thing, but it's absolutely essential that we do that.
I think we're also looking at an understanding of an issue of loyalty. Mm-hmm. Many of the victims have a sense of loyalty to the trafficker because of that bond that I keep talking about. And if medical personnel doesn't understand that there is that loyalty, they get confused by, well, they don't want to talk about anything happening to them and they don't want to say what's happening to them, so therefore, what can I do? What they can do is understand that there may be that loyalty and approach the issue in a different way. Sometimes it's as simple as saying, in the case of Roxana, she has told me before, she says, I wish that they would have just said to me, you can come back here the next time that you have a fight with your partner. As simple as that. Treat it with some normalcy to her, and it would have felt safer.
Let me just ask you, what time of day and what part of the week, is there any sense that trafficking victims are brought in, like late Saturday night after they have been abused to the point where they break down and are unconscious? Or because I remember I traveled with the proactive unit of the Trenton Police, second term, so it was like 32 years ago, and they brought in a woman who had been raped, who was unconscious. And she was so badly beaten, I almost cried. I just had to hold back. I felt so bad for her. But there was a matter-of-fact attitude towards her that, and again, trauma people see it all the time, and for them it must be, they just steal their emotions. But I kept looking at this poor woman who was just battered and wondered, did they catch the guy? Did they, and so do you find there's a certain time of the week, certain hours of the day that traffickers bring their victims in?
I think that since victims have to work 24 hours a day, 7 days a week, that they can be beaten at any time and be brought in at any time. That's my thought on it. I'm interested to hear what the others.
Same here. I have not found a specific pattern on times. I know in the state of Florida, the busiest days for the brothel activity is Mondays and Saturdays. However, in my cases that I have worked, no specific pattern on when they're taken in. It just basically happens when it gets to that point where there's nothing else the trafficker can be pushing for.
Could I, I'm sorry. Dr. Chang? The WHO, part of my subcommittee, it's called Africa Global Health, Global Human Rights, and International Organization. So the UN does come under. And, I have followed with great interest, have been up to the UN. I'm the special representative for the UN this term. It's the third time I've done it over the years, over 35 years, as a member of Congress. But the WHO, comes under, we deal with them all the time. I have a big hearing, for example, next week on tuberculosis, particularly multi-drug resistant. And the TB has just sounded the alarm for just how dangerous, and I know some of the trafficking victims do suffer from that, as well as HIV, AIDS, and other diseases. But I'd like to follow up on the WHO side with the codes that you spoke about. So again, anything specific you could provide. With the post-2015 Sustainable Development Goals, we tried very hard to get more explicit language on combating human trafficking for the global effort, which will be in effect for the next 15 years. But specifically on WHO, I'd love to follow up with you on that, all of you if you'd like, but because I think that's something that needs to be done.
We could really use the help. We have submitted the proposals, and the ICD-11 is the new coding edition, and that is in its beta phase through 2017, and that means that people can provide proposals for change, and people review them during this time. And so if we could have your support in saying, these are good, this is a good idea, or, this is a good idea, but I suggest you change the wording. We're open to suggestions, but we really need support to make it go through. So I would love to be able to talk to you a little bit more about that in specific details.
Very good, thank you. We'll do that. We did check with the two community health centers in my district, and while they're interested, they don't have something. So I'd like to follow up with you on that and try to get that going in our area. Thank you. Just a couple of final questions, and maybe we could turn that off and just ask one or two final questions of our two other witnesses. But the Federal Strategic Action Plan, your thoughts on that? Obviously, it began in 2013. Are you encouraged by its as it's taking shape?
Go ahead.
Yes.
I am actually very encouraged by it. I think there has been a great push for victim-centered services. Department of Health and Human Services is involved now, and I think the Health Resources and Services Administration side is involved as well.
I'm also very encouraged by it, and the only thing that I would suggest at this point that I would like to see with it eventually in the future is that more specific on protocols and what to do, especially with the healthcare system, a little bit more of that.
I'm very encouraged by it as well, in the sense that it very strongly advocates for a victim-centered approach and increased victim services. I do also appreciate the idea that whatever we do, we need to make sure that we look at outcomes measures and test the efficacy of these various strategies. It's not enough to come up with great ideas that feel good and start implementing all these programs. We need to measure the outcomes and make sure that they're actually working and helping victims.
I agree with that.
Roxanne had talked about the rehearsed story. Is that common as well?
Yes. Almost every single time.
And the pimp or person that is accompanying her knows very well what she has to say. And if she doesn't say it, there's retaliation.
Yeah, in all of the cases that I've worked, there is a rehearsed story. It's a little different every time, but it always appears to be a very normal story.
And finally, the National Symposium in 2009 on the health needs of human trafficking victims had a number of important points, including cultural competency or the lack of it, the illiteracy issue. I mean, how often, particularly in an emergency room, does that present itself where the attending or the LPN or nurse just doesn't get it because they don't understand the language or the nuances? They did say the consequences of human trafficking on mental health cannot be overstated, and I think that is a huge issue that's gone unfocused upon. And we know more about PTSD and other trauma consequences than we've ever known. Is it being applied effectively to these trafficking victims? I wrote a law called the Torture Victims Relief Act, 3 of them as a matter of fact, which provides torture centers and best practices for dealing with torture victims. And we have about 500,000 in the U.S., mostly came here, obtained asylum from a country that was a dictatorship, Africa, Latin America, Europe, Russia, China. And what I've learned from all of that, because we've had witnesses tell their stories, that the trauma continues for decades, not years, but decades, unless dealt with. And I'm wondering if we're doing enough on the mental health side to address that, because that can be disguised. Antidepressants can cloak it. Maybe they're needed. I'm not saying they're not, but getting to core issues is, so maybe you might want to speak to that. And then that leads to the other issue of re-victimization, which they also discussed at length at the symposium. They just give up, or they're coerced back into it, but sometimes it's a matter of such utter brokenness that they give up.
I think that you make an excellent point. We can treat the gonorrhea. We can treat the closed head injury. We can treat the fractures and the burns, but it's extremely hard to treat the post-traumatic stress disorder, the suicidality. In one study of child survivors, 47% had attempted suicide in the past year. That's a very large percentage of adolescents. And I think that there are some promising actions. The trauma-focused cognitive behavioral therapy is a very effective, evidence-based therapy that's very good for sexual assault victims and sexual abuse victims. And they're working hard on tweaking it so it is appropriate for human trafficking victims. So it's in its early stages, but there's some promising evidence on that. But again, everything has to be evidence-based. And so I think people are really aware of that. They're saying, okay, we're going to tweak this strategy, but we've got to see if it really works. But it is promising.
Yes, Dr. Chang.
So one of the promising things about the community health centers is that there's the push for the integration between primary care and behavioral health services. So we are trying in our human trafficking or commercially sexually exploited minor program at Asian Health Services to include the behavioral health side to that.
I think it's essential. I think that we could still make more progress with it, as previously mentioned. Evidence-based services should be the key in, of course, outcomes. We do need to start obtaining some types of outcomes on what best practices are, what works, what doesn't. Yes, I think all of this, yeah.
Is there anything you'd like to add as we near the end?
I'd just like to thank you so much for focusing so much attention on this issue, because it is something that is desperately needed. And thank you very much for your efforts.
Same thing. Thank you so much. And on behalf of all of the victims that I have personally worked with, thank you.